بسم الله الرحمن الرحيم. أنا الدكتور أيمن الدرف، أستاذ مساعد النساء والتوليد بكلية الطب جامعة طنطا. النهاردة إن شاء الله our lecture will be heart diseases with pregnancy. As a start, we must know that the incidence of heart disease with pregnancy ranging from 0.4 to 4%, and this usually is according to the New York Heart Association classification of cardiac diseases. Regarding the classification of 3 and 4 New York Heart Association, the incidence of heart disease is about 6.8%. And nowadays, you must know that the mortality due to heart disease has decreased, and this is usually due to the advances in medical fields in general and the cardiology in specific. And the developed countries, the maternal mortality rate due to heart diseases has increased. Why? This is a false increase. Because the cause of increase is usually the advancement of medical conditions in the field of cardiology, especially in the young age. So they have the chance nowadays to get pregnant, and of course, this will increase the incidence of maternal mortality. The etiology of heart disease to pregnancy, as in general diseases, the incidence or the etiology of heart diseases may be congenital or acquired. The congenital may be operated، يعني عملت operation قبل كده ولا لأ or unoperated. The acquired may be infection, autoimmune, degenerative, ischemic, or idiopathic. Idiopathic is not common, but the common here in Egypt is the autoimmune, and of course due to rheumatic heart diseases with pregnancy. Regarding this figure, as you see, the adult congenital heart diseases represented about 35%, but the valvular heart disease represent about 40% of all heart diseases. But sometimes, or some sorts of congenital heart disease like pulmonary hypertension, cardiomyopathy, are less incidence than the adult congenital heart diseases and the valvular heart diseases with pregnancy. Pregnancy with heart disease in general has increased, and we said before this is due to the presence of advancement in the cardiology, in the cardiac surgery, specific in young ages. But in developed countries, rheumatic heart disease is decreasing, and this is usually due to the advancement in the medication or the treatment of rheumatic heart diseases in childhood. So this patient, when become pregnant, the incidence of rheumatic heart disease is decreasing. Regarding the congenital heart diseases with pregnancy is also increasing, because this patient in the past they didn't have any chance to get pregnant, but nowadays they have this chance of getting pregnant. Regarding the evaluation of heart disease with pregnancy, as all of us know that the New York Heart Association, there is a classification in this done by this association, which is in class 1 there is no symptoms and no limitation of ordinary physical activity. In class 2, either slight of limitation with mild to moderate activity but no symptoms occurs at rest. In class 3, there is a marked limitation with less than doing daily activity like dyspnea or pain and minimal activity. But in class 4, the symptoms occur at rest and with minimal activity, or the symptoms of frank congestive heart failure occur. Regarding the effect of pregnancy of heart diseases, you must know that there is aggravation of the cardiac condition by 1 grade according to the New York Heart Association. And this means if the patient is grade 1 before pregnancy, she will be grade 2 during pregnancy, and if it's grade 2 pre-pregnancy, it will be grade 3 and like so. Regarding the heart failure, there is three duration or three timing of occurrence of heart failure. The first one is at the 30 weeks of pregnancy, which is a period of maximal increase in the cardiac output and the blood volume during pregnancy. Also, heart failure can occur during labor, especially at the second stage of labor, which is the stage of maximal cardiac effort and is the stage of maximal peering down, and also in the third stage of labor. Why? Because the passage of the placental and uterine circulation towards the systemic circulation. Sorry. And heart failure also can occur during puerperium due to the return of extracellular fluid to the maternal circulation. Infective endocarditis can occur at any time of pregnancy, but it's usually occurs during puerperium. Regarding the hemodynamic changes on normal pregnancy, as you see, there is increase in the plasma volume, cardiac output, heart rate, mean arterial blood pressure, stroke volume, but there is increase in the systemic vascular resistance and the pulmonary vascular resistance, which is a protective mechanism that prevents the occurrence of hypertension and pulmonary systemic hypertension and pulmonary hypertension. So it's an adaptive mechanism for the pregnant lady towards the increase in the cardiac output and the plasma volume. This adaptive mechanism is the decrease in the systemic vascular resistance and the pulmonary vascular resistance. Regarding the effect of heart disease in pregnancy, the maternal, there is increased morbidity and mortality rate, of course. There is impairment of the rest and there is restriction of the lifestyle and may be premature and preterm labor. Regarding the fetal condition, there is a spontaneous increase in the incidence of spontaneous abortion, increased incidence of prematurity, intrauterine growth restriction, and intrauterine fetal death and neonatal death. And this is usually by decreasing the oxygenation of the fetus or the impairment of the fetal circulation. So, if there is a low fixed cardiac output, this means low placental circulation, low increase in or impairment of the increase in the fetal body weight, and this will lead to prematurity, intrauterine growth restriction, intrauterine fetal death, and neonatal death. Regarding the symptomatology of heart disease pregnancy, you must know that the symptoms of normal pregnancy more or less mimic the symptoms of heart disease, so it may be difficult to differentiate between symptoms of heart diseases with pregnancy and the symptoms of pregnancy. So, what are the symptoms of heart diseases? It may be breathlessness, syncopal attack, episodes which about 90% of normal pregnancy. There is atrial and ventricular ectopic peaks which are common, and about 96% of women may have an audible ejection systolic murmur, and 84% of women of pregnancy may have a third heart sound. So breathlessness, syncopal attack, ectopic beats, ejection systolic murmur, which are common. Also, there is a murmur over the right and the left intercostal space, which may be systolic or continuous. These murmurs are common and are due to mammillary vessel blood flow. When we do ECG for a pregnant lady with cardiac disease, there is a depression of the ST segment and a Q wave in the lead 3 and the T wave flattening or inversion of V5, V4, V5, and V6. This is somewhat important for the cardiologist, but you must know there is a depression of the ST segment. What are the investigation we need for this? We need to do electro ECG, echocardiography, Doppler echocardiography, and exercise tolerance test. In sometimes, especially in infective endocarditis, we may need for the acute phase reactants like the C-reactive protein and anti-streptolysin or tetr if we suspect streptococcal infection. Regarding the cardiomyopathy, we have a peripheral cardiomyopathy. This peripheral cardiomyopathy is very rare, very, very rare. It carries a prognosis of 25 to 50% of mortality, and as it's associated with hypertension in pregnancy, the patient is pre-pregnant normal, then pregnant with hypertension, and it may occur also with patients with multiple pregnancy, with high mortality and decreased maternal age. It usually occurs in the puerperium, but may occur also in the last weeks of pregnancy. And it presents with sudden onset of heart failure. Regarding peripheral cardiomyopathy, there is a grossly dilated heart in echocardiography and treated by Lasix, which is diuretics, nitrate, angiotensin-converting enzyme inhibitor, and digoxin-heparin, and reduces the risks of thromboembolism. Termination of pregnancy is done ideally vaginally if it occurred antenatally, and the termination of pregnancy may be the rule and may be the solution for occurrence of cardiomyopathy. If there is a good initial recovery, the long-term prognosis is good, although there is increased risk of recurrence and future pregnancy. So in peripheral cardiomyopathy, the patient is at the start is hypertensive, and it occurs in the puerperium and may occur in the last weeks of pregnancy. And if it occurs in the last weeks of pregnancy, the solution may be termination of pregnancy, and we treat peripheral cardiomyopathy by furosemide, nitrate, angiotensin-converting enzyme inhibitors, and digoxin and heparin. In peripheral cardiomyopathy, it has the chance, or there is increased risk of occurrence in a future pregnancy. In hypertensive cardiomyopathy, this is generally well tolerated in pregnancy, unless there is severe outflow tract obstruction and heart failure. So hypertensive cardiomyopathy is clinically well tolerated than peripheral cardiomyopathy, but there is a risk of sudden death is probably increased in pregnancy. In hypertensive cardiomyopathy, we must avoid the occurrence of bleeding and the occurrence of hypovolemia. So the anesthesia with hypovolemia, like epidural and spinal anesthesia, may be used with caution. And the antiarrhythmic drugs may be required, like beta blocker, is allow increased ventricular filling. How can we do management for heart diseases with pregnancy? We have general management and we have specific management. Regarding general management, we must have more frequent antenatal visits, more period of rest. The diet is directed to restrict weight gain and prevent anemia. The diet must be rich in iron, low restriction and there must be a restriction of salt, and decrease in the physical and mental strain and anxiety. Infection should be avoided by proper use of antibiotics. At any time, if there is a signs of decompensation, we must transport or transfer the patient to the hospital for hospitalization, and we must prevent the heart rate to be more 100 beats per minute. More period of rest is very important, especially in the last 2 weeks of pregnancy. Regarding the medical management, as in heart diseases in pregnancy or without pregnancy, we have digoxin, which is cardiotonic agent. It's indicated in atrial fibrillation and used also to slow the ventricular response in acute heart failure and to increase the myocardial contractility. Regarding diuretics, it's a matter of controversy. Sometimes diuretics are contraindicated for the occurrence of oligohydramnios, but in another times diuretic can be used, especially if there is acute or chronic heart failure. We must do potassium supplementation and prolonged therapy with diuretic. We may use beta-adrenergic blocker as propranolol may be indicated for cases of arrhythmia associated with ischemic heart failure. Also, we may use the aminophylline, which is important for relief of bronchospasm. It's a bronchodilator. Also, we may use heparin, especially in cases of artificial valve or of there is atrial fibrillation. Regarding also the specific management, in cases of acute pulmonary edema, it's treated by, as we also, all of us know, we treat pulmonary edema by the occurrence or by the using of diuretics warfare, about 50 milligram intravenous, by oxygen, by digoxin, which is cardiotonic, by aminophylline, and maybe venous section to decrease the prelude of the heart. Regarding the specific management, which is the surgical management, we may do specific therapeutic abortion should be considered in class 3 and 4 if they occur. If the pregnancy occur in class 3 and 4, we must do therapeutic abortion. If they seen early in pregnancy, again, if the patient is class 3 or class 4 at the start of pregnancy, we must do therapeutic abortion. Why? Because these patients are very liable occurrence of heart failure in pregnancy. Cardiac surgery, it may be alternative to therapeutic abortion. The principal indication is recurrent pulmonary edema with mitral stenosis and heart failure, not responding for medical treatment. There is no increased risk to the mother or the fetus, includes cardiac surgery, like mitral valvotomy, but there is a higher incidence of fetal loss with open surgery. In general, open surgery or cardiac surgery in general, it's not recommended during pregnancy. We must prevent pregnancy before correction of this of the cardiac lesions by surgery. This is very important. If we are planning for occurrence of pregnancy, we must do surgery at the start and then allow the patient to get pregnant. But if the patient is getting pregnant and the patient is class 3 or 4, we must do termination. Cardiac surgery is done only for cases of pulmonary edema. During labor, there is no indication to induce labor of any cardiac diseases unless there is heart failure. If there is heart failure at any time, you must, parallel to the management of heart failure, you must do termination of pregnancy. If induction of labor is indicated for an obstetric cause like antepartum hemorrhage, we may use amniotomy, oxytocin, and concentrated glucose solution, which is the best method. We must minimize the incidence of infection and fluid overload to prevent the pulmonary edema. Induction of labor never be taken in patients with acute heart failure. After the correction of the heart condition, you can do induction of labor, but at the period of heart failure, you must not do induction of labor. In general, vaginal delivery is more easier and preferable to cesarean section, but should be an easy and not a prolonged one. There is no place of trial of labor in cardiac patient. There is no place of trial of labor in cardiac patient. Why? to decrease the burden on the heart, especially in the second stage of labor, to decrease the incidence of heart failure. At the second stage of labor, you must shorten this stage of labor by any method you can, by using forceps, maybe by using uh, ventouse, maybe, but you must decrease the second stage of labor. During labor, there must be a bed rest in the sitting position, or give oxygen by mask or ventilation of the heart failure or cyanosis developed. You must give adequate analgesia like Pethidine or morphine. You must shorten the second stage by forceps and ventouse. Ergometrine, which is ergot alkaloid, it's forbidden because of the fear of heart failure, the fear of stroke in this patient, the fear of pulmonary problem. So ergometrin is better avoided. Prophylactic antibiotic is so important for guarding against subacute bacterial endocarditis, and you must observe the patient for about 48 hours. It's essential, as the risk of heart failure is high in this period. Also, bed rest is essential. Early ambulation is also preferred for prevention of thromboembolism. Sorry, breastfeeding is allowed unless there is heart failure. Estrogen shouldn't be used to suppress lactation, and bromocriptine can be used. Sterilization may be advised in some cases if the compensation occurred in this pregnancy, and the best sterilization may be by tubal sterilization. This is the end of our lecture, and thank you. حلو، خدتها في 21 دقيقة. أنا خلصت.